I want to jump into endometriosis, Dr. Briden.
A profound, actually, disconnect between the presence of the lesions and pain. So we already know some women can have extensive lesions, have zero pain, zero problems with fertility.
Interesting.
And conversely, some women can have a lot of pain and have either no lesions or just a few superficial lesions.
The bacterial contamination theory of endometriosis. It's also speaking to the vaginal microbiome. Am I correct?
A super high number of women with persistent pelvic pain or endometriosis have SIBO, or have irritable bowel syndrome or potentially small intestinal bacterial overgrowth, which then causes intestinal permeability, which then this is potentially a source of that inflammation. So one, from a functional health, naturopathic health perspective, you really cannot go wrong with.
I remember that first surgery going into it, my surgeon said to me, if you were my daughter, I wouldn't be doing this.
Hello and welcome back to the Vibrant Wellness Podcast. I'm Dr. Emmie Brown alongside my co-host, Melissa Gentile. Today, we have the great pleasure of speaking with Dr. Lara Briden, a trailblazer in naturopathic medicine and a respected authority on women's health with nearly 30 years of experience. Dr. Briden is not only a clinician, but also a best-selling author with influential works including Period Repair Manual, Hormone Repair Manual, and her newest release, Metabolism Repair for Women. At her practice in Christchurch, New Zealand, Dr. Briden is deeply committed to empowering women through achieving healthy menstrual cycles without hormonal birth control and using science-backed natural treatments for PCOS, PMS, endometriosis, and perimenopause. Today, we are thrilled to welcome her to help us learn more about her innovative approach to endometriosis, blending rigorous scientific research with holistic healing. Dr. Briden, thank you so much for being here. We're thrilled to welcome you.
Oh, thanks, guys. Thanks for having me. It's great to meet you.
Absolutely.
We're so excited.
Okay, so before we dive into endometriosis and all things women's health, you have a strong research background, Dr. Briden, as an evolutionary biologist. How did you come to find naturopathic medicine and become interested in women's health?
Yeah, well, let's start with the women's health part, because my original work as an evolutionary biologist was in sex differences in foraging behavior of different animal species. I published a peer-reviewed paper about that back in the early 90s. And so looking back at some of the other papers and that paper I was writing back then, I thought, oh, wow, I was really interested in female physiology, female biology right from the beginning, and always sort of framing it as the normal, like the standard normal version of human physiology. And then the way I like to frame it is, male physiology is a little bit quirky if you think about it. Got some unusual things going on.
Yeah.
So, I mean, of course, both male and female are normal. But so then I was considering becoming an academic biologist, like a research biologist. That was part of where that was my road not taken, I guess, if you will. Like that was the other place I was considering going. But then I just had some heart-to-hearts with friends and family at the time, and I realized I wanted to work more with people and also maybe have a bit more flexibility with my career. So I did change paths and trained as a naturopathic doctor in Canada. Even though I live in New Zealand now, I'm Canadian, and loved it. Like when I started out in general practice, I was in rural Canada. So a lot of my early patients were ranchers and farmers, and school teachers, like just like people who had a very pragmatic view of life. And so I was able to learn right from the beginning how well some of these natural treatments work. And my then shift back to women's health came just from the sheer number of women who came to see me. And so you can imagine, starting in the 90s, the mid to late 90s, there were a lot of surgeries, high dose birth control, high dose old school Premarin hormone therapy. Like there was women were dealing with a lot, and they needed alternatives. And fortunately, a lot of what we learned in naturopathic college worked. So I was able to see that on the ground, be it frontline naturopathic doctor for a couple decades. And then I just had to put that into some books, basically.
Yeah. You really fulfilled that need, and you make such a good point. There's so much mainstream acceptance at that time, and now we're hearing a lot more maybe confusion or questioning around birth control, which we'll get into later. And I think that's all for the best, because patients are really becoming their own advocates, which is
Yeah.
fantastic. And your book helps patients become their own advocates, which I just love so much. So, speaking of women and particularly young women, their first period is generally somewhat stigmatized for many of them. It can be a source of confusion or even shame. So, I'd love to know, what are some maybe myths around periods that you would like to dismantle for people listening?
Yeah, I think the core, maybe not myth, but like a reframing that I like to do for young people for those early years of menstruation is framed as this is so you can make a baby in the future. And that's,
Mhm.
that's true. Obviously, that is like 100% true, but it's also not the whole story. And it does bring sex into it right away and whether they even want a baby or not. But the other way to think about it is that the menstrual cycle kicking in and that communication between the brain and the ovaries kicking in is how girls and then teenagers and then young women make hormones, the hormones we need to be healthy. So those are our two main hormones, estradiol and progesterone. They're very important for the brain, for metabolic health. Estradiol is anabolic, so it helps build muscle, helps with sports performance in teenagers. That's something a lot of them do resonate with. And it's quite strange because like for boys, we know that. We don't say to boys, you're entering puberty so you can make a baby. Like we're like, you're now making
Great point.
testosterone, so you're gonna like grow into it. You're gonna grow taller,
Strong.
you're gonna make muscles, it's gonna change your personality. Like it's like you're becoming a man and you're becoming an adult. And it's exactly the same for a girl. I mean, whether they ever go on to have a baby or not is not really the point at that stage. So I guess that's the reframing I would offer. And I do find just practically that does resonate with a lot of girls. And even around, which I know we're going to come to the pill, but even around decisions around whether they take the pill and shut down all that natural hormone production, it's more meaningful to them to communicate that's potentially then robbing you of, for example, estradiol, which is going to you need for making good muscles and having good mood. And so I think it just makes it a bit more immediate for girls. It's interesting around the stigma around the bleeding itself. I would have thought that was less than it had been. I know even when I first released Period Repair Manual almost 10 years ago, more than one person advised me, like, do you really want to put the word period in the title of a book? Because that's quite off putting. But I don't think that's how it is now. Like, shortly after that, around 2015, there was or 2015, 2016, they called it the year of the period. There were athletes free bleeding, and it was sort of this reclaiming of menstrual blood is normal and can be talked about. So I hope it's better for girls now. Yeah.
We hope so, yeah. And I want to pull on something you just mentioned maybe a minute ago, just about all the benefits of all these hormones that we start producing. I think there's a
Yeah.
huge gap in education kind of at that age. And I think birth control is kind of, we're going to get into that later in the episode,
Yeah.
but I think it's kind of forced upon us a little bit. It's kind of like the end all solution for a lot of different things. And we don't realize we actually need our natural hormone production for so many other things. It's not just the PMS we experience, it's like affecting our brain, like you said, and so much else. And I remember a couple of years ago when I read your book, Period Repair Manual, when I was looking for my own health solutions, you talked about the importance of ovulation. And I had no idea the importance of ovulation and how it affects progesterone and all these things. So can you kind of walk us through like what are some of those key signs of a healthy cycle and like why is ovulation so important to us?
Yeah, absolutely. So ovulation is how women make hormones. I mean, men are quirky. Remember, I said men are a little bit quirky. They make their testosterone every day, which is weird. You know, women we make it on a monthly cycle. So early during the bleed, which is the early days of the cycle, there's very little estradiol. Like it's basically down at menopausal levels at those days. That's normal. And then obviously as the cycle, if all's going well, the cycle kicks in. As it progressing to ovulation, we get this big dose of estradiol. A lot of women feel amazing during that time. We also get a little uptick in testosterone at that time, which feels women really are very sensitive to, usually in a good way. Although it can, I think, cause any movement of the hormones can in women who are sensitive to it for different reasons cause symptoms. So I will acknowledge that as we talk about it. But for a lot of women, this feels really good to have estradiol go up. And then, yeah, as you said, the only way to make progesterone is to ovulate. And yeah, and progesterone has its own benefits. It's unfortunately progesterone there's been a lot of confusion around it. A colleague of mine calls it, there's been a weird vibe around progesterone for a lot of years. And I have a blog post called How Science Got It Wrong around progesterone. A lot of that stems from, there's always a history lesson in there, which I won't go into here, but scientists actually weren't able to kind of make real progesterone into pill form until really late in the game. And so they substituted all these progestins, which are often called progesterone, but they're really not. And progestins can have, like, for example, opposite effects in the brain, whereas progesterone for many women is calming, feels good, promotes sleep. Progestins, as we know now, all of them to some extent, and some of them more than others, are associated with anxiety and a reduced ability to cope with stress. Just responding to something you said earlier, I can't remember how you phrased it, but I just want to sort of again do it as a reframing. So yeah, sort of embracing female hormones is a good thing. There's sort of a few things that are all true at the same time. So we've had this narrative. It's really like since medicine started talking about women's hormones, that female hormones are in some sense a liability. Like they're pesky. They potentially cause mood symptoms sometimes, although I would argue they don't really. But they make periods heavier. So there's this idea that female hormones are something to be managed, or
like a burden.
A burden. Yeah. And obviously most methods of hormonal birth control shut it all down. Like just the approach has just been shut it all down. And then the second thing that is weird is that then it's like, but these synthetic hormones, progestin and plus something called ethinyl estradiol, which are not real hormones. They're different molecules. They have different effects. It's primarily different effects in the brain, different effects everywhere, really. But then they're put back in. It's like, well, female hormones are bad, but these synthetic hormones are going to be good enough for health, sort of, because they have to always acknowledge, well, we do need estrogen. And then at the same time, weirdly, I don't know if you guys, this touches on the perimenopause thing a little bit. Now, as you know, we've got like this huge amount of enthusiasm for how beneficial estradiol in particular is, and progesterone to some extent, for women in perimenopause and menopause. It's like, oh, you must take it because estradiol is always good for the brain. It's good for all these things. I mean, great. We can debate that. I sort of agree with that to some extent. But then what about all the young women who we've switched it off? Like, didn't they need estradiol? Like, why do young women don't need it at all? But suddenly when you're 45, you must have, like, it's a very strange, we're kind of in a very strange place with female hormones. It's like partly gotten through that female hormones are beneficial, but only for older women somehow. So, but yes, young women benefit from their own hormones.
It is like an obvious thing to state. It's so interesting that we think we can make something synthetic better for us than what our own body is made to produce. Where did that notion come from? It's interesting.
Well, I mean, the history lesson is that's what they had, right? So this is what they'd made. They're like, well, it's kind of, I think it was more just wishful thinking. Oh, that'll be good enough. Like, surely it's close enough. It's like kind of fudge that. It's like, well, they're not really hormones, but they're pretty close. So we'll just go with that. And that's where we've been. And of course, now the evidence is emerging. Yeah, they're not hormones. They do have different effects on the brain. For example, on breasts, which is another big one, actually, all progestins, so I can say it this way, all progestins slightly increase the risk of breast cancer. I mean, I put emphasis on the slightly because anytime this comes up, I don't want people to be overly afraid, or the additional risk is small, but just as compare and contrast, all progestins slightly increase the risk of breast cancer. Progesterone probably decreases it, which is an illustrative point. I guess that's why I bring it up.
And I want to jump into endometriosis, Dr. Briden, and speaking of estrogen and how it's not so black and white. Of course, there are benefits, and I think that it's on a spectrum of maybe too much estrogen or not enough estrogen, and depending on what kind of pathology we're looking at. But let's frame this within endometriosis. So before we jump into the hormones and how they act or maybe impact pathogenesis in endometriosis, what is endometriosis as a review for our practitioners listening?
Yeah. I have some things to say about it because endometriosis it is undergoing a bit of a paradigm shift right now. We're in the middle of that. But I guess in simplest terms, like just to start out really simply, it's a situation where tissue quite similar to the uterine lining or endometrial tissue is found in locations other than inside the uterus. So they call them lesions. So there's little pockets of this tissue, and it's potentially quite active tissue that it could be typically around the ovaries or really anywhere in the pelvis. And it's associated with pain and potentially with infertility. So it can be inflamed tissue. Would you guys add anything to the basic definition? I guess, is that a good place to
That's a good place to start. Absolutely.
Yeah. And it is estrogen sensitive tissue. So it for sure is, because as the uterine lining is, so of course it's going to be estrogen sensitive.
There.
So that's built into it. Sorry. Yeah.
Yeah.
The paradigm shift, and I will just bring another expert into this, another name of someone you could maybe have on your podcast if you haven't already. Down here in Australia, in Brisbane, there's a gynecologist named Dr. Peter Wright. She has a book called Healing Pelvic Pain. And she's a gynecological surgeon. So she worked quite closely with another surgeon named Thea Bowler. And they're both amazing. I just saw them a few weeks ago, actually, in person. So you could bring them on your podcast and you could continue the endometriosis conversations. So they now speak in terms of persistent pelvic pain / endometriosis, like as kind of more of a continuity, because as they can explain in better words than me, I'm sure there is quite a profound, actually, disconnect between the presence of the lesions and pain. So we already know some women can have extensive lesions, have zero pain, zero problems with fertility.
Interesting.
And conversely, some women can have a lot of pain and have either no lesions or just a few superficial lesions. And so Peter and Thea are really bravely raising the question, like, how do the lesions actually fit into all this? And isn't persistent pelvic pain maybe just a much bigger conversation? And this is another history lesson, because the reason we think about endometriosis the way we do is it was first described by surgeons. So they saw these little brown lesions. They're like, oh, well, that must mean something. And so that was about 100 years ago. So we've had this whole kind of paradigm set up around identifying the lesions and figuring out what's causing them and cutting them out potentially. And so Peta and Thea and myself will acknowledge, I mean, certainly there are different types of endometriosis lesions, as you probably know. So there's just the superficial ones. Then there's like deeper infiltrating ones. There's something called endometriomas, which grow on the ovaries. So some of those, and they're arguably actually just quite different from each other in terms of their origin and how they behave. And so certainly the deeper infiltrating ones, I think most people agree, are causing symptoms, causing pain. The question is really more around how significant are the superficial ones? And because they do tend to come and go. And this idea that endometriosis is a progressive condition that will just keep getting worse and worse if you don't address it, is probably not true for superficial lesions. They tend to just, like, Peta even raises the question, like, are they just physiological in some women? Like, they're there for a while and then they go. And a lot of the time, you can also then bring in, what my work has been more around before Peta and Thea raised this uncomfortable question, like, how important are the lesions in the first place? Mm-hmm. A lot of my work had been around, yes, like if the lesions are inflamed, it's not because of the tissue itself per se. It's actually because of how the immune system is responding to that and the reaction around that. And there does seem to be sort of an autoimmune component around that. So basically, I think it's fair to say that in a lot of cases, women with persistent pelvic pain have inflammation in the pelvis. I mean, that's pretty clear, I think, almost through any lens. And a lot that inflammation could involve inflamed lesions for sure, but it could also just be diffuse inflammation. So at the end of the day, especially when you start talking about natural treatments, the things we do to reduce inflammation or help to sort of normalize immune function works almost regardless of how many lesions there are, like the lesions themselves. Does that make sense to you guys? Have you heard that from anyone else? What's your response? Yeah.
I haven't, but it's so valuable because you're always asking questions. And I think that's why I gravitate towards your content so much, and asking, is our definition of this condition even correct? and doesn't evolve based on the research. Of course it does. It should.
Yeah.
And so I find that so valuable and fascinating, and that really helps us understand, especially for women who are thinking laparoscopic surgery is the only way to officially diagnose endometriosis. I think that can be very reassuring to hear. Would that even be valuable if they don't find much and they can do these kind of low risk interventions despite maybe the degree of lesions they have, is what I'm hearing.
Exactly. That's what, and when you talk to PETA, you'll see that's pretty much what they're saying. You can, and they do talk about how what women, the important thing, because women are, especially women who've been in a lot of pain, and Melissa will hear from your story, but like obviously the main thing is to be believed and to have some explanation and to just have some hope. And one downside to hyper focus on lesions actually is for all the women who have a lot of pain, get the diagnostic surgery, and don't have lesions. And then they're just kind of left as like, well, you don't have endometriosis, so sorry, I don't know what's going on with you. And that's actually that's a good portion. It's probably, well, PETA will give you the numbers, but that might be like 50% of women with persistent pelvic pain end up not having lesions. So you sort of have to take a broader lens with things. And also first and foremost, believe women when they say they're in pain and just convey the message. It's not normal to have serious pain, and there are lots of solutions. What do you think, Melissa? Because obviously this is a topic. Yeah.
It's interesting. The first surgeon that I went to, we did the whole 9 yards, did all the ultrasound, all the blood tests, all this, that, whatever. And it's like nothing was coming up. And it's also hard to get MRIs covered by insurance if there's no like real reason to, because sometimes they can show up on MRIs, which mine later did on an MRI. But I remember that first surgery going into it, my surgeon said to me, if you were my daughter, I wouldn't be doing this. I wouldn't be doing the diagnostic surgery. I would just be handling this. There's nothing wrong with you. I think that was the most invalidating thing I've probably ever heard throughout the journey. And I have kind of I don't want to say lucky story, but to get diagnosed in 4 years is pretty good from the stats that I've looked at. Some people are getting diagnosed between 7 and 11 years. I know those stats kind of fluctuate a lot, and I can't imagine how many people are walking around undiagnosed because it's so difficult to diagnose. And it was interesting too, because when I did go through the diagnostic lab, that one surgeon that said, you really shouldn't be going through with this, he said the case was so bad that he couldn't do anything about it and referred me out to somebody else. So it is really interesting. It was kind of one of those moments. It's like, well, see, I told you so. Like, listen to me next time. But I think that's from what I heard here, this is a really common kind of scenario. So, I mean, just in the diagnostic timeline alone, like taking so long to get diagnosed, why is that in your perspective? Or what should we be doing as practitioners to try and look for the signs, or even if you're a patient listening in, what are those things that you should be asking yourself? Because I remember even myself going through it, I was getting hip x-rays. I'm like, do I have a hip injury? I think we kind of get in our head, like, what's going on? Yeah. Like, what are some of those things that are kind of telltale signs that, maybe you really should consider doing a diagnostic lab or just looking into kind of what else is going on?
Yeah. Well, before we get to that, I mean, I'm happy to try to answer that as well. But if you're willing to share, I don't know how you feel about sharing. Like, do you know if you had the nature of the lesions? I mean, you said it was pretty bad. Did you have the sort of deep infiltrating ones or endometriomas?
Yeah, so no endometriomas. There were 6 lesions and 1 was deep infiltrating.
Okay. Yeah. Right. So that's a story where, as I said earlier, like, and again, I don't want to misquote PETA and Thea. So you'll have to, if you get them on, you'll have to ask them to explain in their own words. But if they're sort of questioning the significance of the lesions, it'd be more around the superficial type. And even they, like, as I said, they're surgeons, so they still sometimes do surgery for endometriosis. So they're not against it. But I think it's a tricky one. You're asking, like, when do you know if you should have a diagnostic laparoscopy? I think part of the paradigm shift is we are moving away from diagnostic surgeries. I think, I mean, I'm speaking collectively. Obviously, there's different experts have different opinions, and it is quite an invasive. I mean, that's why there's as you're quoting, like the 9 or 10 years to diagnosis, because diagnosis has required surgery, and for lots of reasons, the patient doesn't really want to do that. Doctors don't want to do that. Parents don't want to. No one wants to put a woman, or especially like a young woman or a teenager, through surgery. Like it's not a small thing. So scientists are in pursuit of, I mean, of how can we, like, what are some non-invasive diagnostic methods? So you mentioned MRI. I mean, there is some movement around sort of scientists looking at different ways to use ultrasound, as you pointed out, like just a standard ultrasound, like not seeing anything on an ultrasound doesn't automatically rule it out. Doesn't rule out the possibility of a deep infiltrating lesion. But there are different, my understanding is, and again, I'm not an expert on the new ultrasound technology, but there are new ways of kind of doing ultrasound, interpreting ultrasound to maybe start to get a better indication. And I think that's a win for women. If we can start to get a sense, okay, yeah, there are these deeper, more significant lesions. Scientists have been hot on pursuit of blood markers or potentially menstrual fluid markers for serum markers, serum markers for endometriosis, which makes sense because that they would be able to find something. And there's a few contenders for that. I don't have the latest sort of update on what they feel are the best options potentially for these biomarkers, but it makes sense because especially if there is an immune aspect to the condition, so a lot of the research, and this is kind of more been in what I've written about, a lot of the research is looking at like those really inflamed lesions. Like when the lesion is significant, then it arguably does have an autoimmune aspect to it almost, like certainly a very dysregulated immune aspect to it. And that disease process will give off biomarkers. Like you should be able to detect that. So I guess, I mean, I personally would like to see non-invasive diagnosis become more standard and become more available, because I really don't, and that's your question, like when should women insist on a surgery? I don't have an answer for that at this point. I'm very torn because I don't really like to see young women have surgery because, well, partly, and again, you can talk to Peter and Thea about this, but it creates scar tissue. So it's not nothing. Going in there will in itself create drivers of pelvic pain potentially. So more and more doctors are nervous about it. And I do feel like, and it's interesting to hear you say how invalidated you felt by your surgeon who didn't really want to do it. And I get that. I think I'm just thinking about Peta's comment that the main thing women need is validation that they have significant pain, right? Like does that change it for you at all, Melissa? Just a total validation. Yeah, there's inflammation there. There's something that needs to improve. Is that as validating as actually seeing the lesion? Or I'm just actually curious to get your thoughts on it.
I think personally, just because of the field we're in and our background, like I was curious to know like the pathology of I wanted to know like what was going on and how I could attack this and kind of research it from that aspect. So I was very someone that was like, I want to know what cells are there. And so I was very specific kind of in that sense. But you made a really interesting comment a few minutes ago too. So you've seen superficial lesions kind of come and go, because that was just kind of one of my lingering questions. I've heard people talk about serapeptase and kind of some different enzymes, but have you seen some of those lesions just kind of get eaten up by the immune system on their own?
100% with patients I've seen. Like an example I could give, and it's easier to, I mean, rather than going in for a second surgery, like I've had patients
Yeah.
whose endometriomas go away. And that's in the research too. Like there's a famous study on N-acetylcysteine where some crazy number of their participants, their endometriomas just went away.
Wow.
I mean, I think that's, and as I acknowledge, an endometrioma or like that more solid structure is actually probably a more significant type of endometriosis than just the superficial lesions. But in terms of the numbers of, and again, I hate to keep deferring to Peta and Thea, but I do think mine is like the prequel episode to when you asked them about some of these points that I've raised, maybe. Yeah, they cite research saying they do go away on their own. It's not, I'm pretty confident quoting them. It's not, endometriosis is not this progressive disease that it's been made out to be. So yes, we have this narrative that the lesions get there, however they get there, and there's different methods of them arriving there probably. And then once they're there, they're just going to keep growing and progressing unless you cut them out or suppress them in some way. And at this point, I just don't think that's an accurate narrative, which is great, which is good, actually. It means it sort of confirms that female physiology is a lot more dynamic than we thought. And I have, even before I encountered PETA and Thea's questions around this, and even before that, even like a few years ago, I was thinking, well, just know as a biologist, as a understanding how the immune system works and physiology, the immune system should 100% be able to clean up those lesions. Like there's no question it should be able to do that. And so then the question would be, well, what if it's not doing that? And if the lesions are legitimately the source of pain, then what is preventing the immune system from sorting it out? And I'll just also acknowledge, just bring into it, like women can have significant pain and not have lesions too. So we have to sort of not forget about them, because they're the ones, how invalidated you feel. Like, think how invalidated some of them feel. And I heard someone present about that, actually, just this terrible, terrible pain, wanting to join the tribe of endometriosis sufferers so she could like finally have some explanations and some validation. Had the surgery, nothing. And then it's like, that's, at that point, that's a really difficult thing to take on as well. And so I guess kind of what I'm saying, definitely what Dr. Peter Wright has been saying, like we can talk about persistent pelvic pain and endo all together, like because a lot of the same, especially from a natural perspective, a lot of the same things work. The goal is just to have less pain or no pain. Well, the goal is no pain, actually, I would think. Do you want to share? Have you achieved no pain, and what would you attribute to, what combination of things do you attribute that to?
Yeah, I don't know. I think a lot of it is lifestyle factors. I think a big one for me I've noticed is just stress and diet. And I definitely want to get into histamine intolerance, because that was something I was not addressing before. And I was eating a plant-based diet, eating tons of tomatoes and eggplant and all of these things, avocados, probably things that were raising my histamine up. And and I want to get into how LPS and the gut and all the other different associations that you've kind of discovered or drawn back to endometriosis, because those were things that I really wasn't educated on, especially from a conventional perspective, that I think made a big difference. And it is an interesting perspective to kind of doing like a second surgery, or even just surgery in general, because it's like I underwent 2 surgeries now, and I'm kind of like, am I left with more scar tissue and more nerve pain than I was to begin with? It's different pain, but it's still pain. So it is kind of a big question, like, should we even be doing surgery on this? But I know our time here is limited, so I do want to get into kind of the nitty-gritty details. And you say that endometriosis is an inflammatory disease that's affected by hormones but not caused by hormones. And I think that's a really big misunderstanding, because I think I see different specialists out there, even in the field of functional medicine, they just lump this in with PCOS and all the other hormonal conditions. And that's not, what I understand from your work, this functions more of it like an autoimmune disease. So can you kind of dive into the immune dysfunction piece of it?
Yeah, I mean, like I said, there's inflammation in the pelvis, and we should definitely make time to talk about the role of the gut. And you mentioned LPS as bacterial endotoxins from the gut, because that's, I think personally, as a clinician, as an ND, that's a huge driver of pelvic pain in women generally. But in answer to your question, the conventional approach. So the conventional approach is 2-prong: cut it out, cut the lesion, surgically remove the lesions, and then shut down estrogen, basically, to stop it from stimulating the lesions. And shutting down estrogen, the reality is, as I said right at the beginning, these lesions are estrogen sensitive. So there's no question really. And also estradiol, our main estrogen, does interact with LPS, with the immune system to some extent. Estradiol can promote pain in the pelvis with interacting with mast cells, with histamine. So estradiol is amazing. It's like wonderful for lots of things, but it can flare up certain types of inflammation and pain. So that's real. So obviously through my lens, then obviously, well, one perspective is you just shut it all down then, like shut down estradiol. But then that robs women of the estradiol they need for brain and anabolic and all the things we talked about at the beginning of the podcast. So the other option through my lens is we actually dial down the inflammation and improve immune function. And then estradiol, women can still have their own estradiol, but it's not flaring up pain, or it's not flaring up lesions. So I've just like shifted the focus from like take it away from, because hormones typically are normal in women with endometriosis. That's my experience. Like, testing hormones in women, often are having, well, if they haven't suppressed their cycles or their cycles haven't been suppressed with hormonal birth control, then they're often ovulating and cycling pretty normally, which is a very different situation from PCOS, which you mentioned. So yeah, my with my own patients anyway, it's like, let's see if we can achieve pain-free or dial down all this inflammation. And then your own estrogen can kind of come and go as it's supposed to through the cycle, and you can have the benefits of that and not the downsides to it. Yeah.
So speaking of more specifics with this inflammatory
Yeah.
component, Dr. Briden, you
Yeah.
mentioned the microbiome, but generally I think
Yeah.
gut microbiome, but you mentioned in one of your podcasts, and I have to just mention real quick, I love that
Yeah.
they're so short and you pack them with information. They're about 10 to 15 minutes for people listening. But you're calm and so articulate, and they're just fantastic. And so that's where we
Okay.
pulled some of this information from. But
Okay, great.
that aside, the bacterial contamination theory of
Yes.
endometriosis, it's also speaking to the vaginal microbiome. Am I correct? It's not
Yeah.
just the gut that we're thinking about and inflammation, but it's everything down there, if you will, for women
Yeah.
that could be an issue.
So, and the pelvis has a microbiome. It's weird, right? But like every tissue has a microbiome, like the brain has a microbiome. Like it's a bit of a shift to think about. Yeah, it's not just bacteria. Obviously, the gut has loads more bacteria than other parts of the body. The microbiome in other parts of the body is quite diffuse and not as populated as some areas. But so really what we're talking about is changes to the pelvic microbiome. So what we do know is women, well, that's for the sake of argument now, we'll say like accept that endometriosis is legitimate diagnosis, that it's a thing. From some of that research around the bacterial contamination hypothesis, we know that women with endometriosis have 6 times higher levels of gram-negative bacteria in their pelvic microbiome compared to women who don't. So that's a lot in anything to do with health. Anytime it's 6 times bigger, that's a significant correlation. And the LPS, so gram-negative bacteria, presumably from the gut, it could be coming up through the vaginal uterine microbiome as well, but it's very upsetting to the immune system. So that's something called lipopolysaccharide, or LPS. It plays a role in other conditions too, actually, in mental health and cardiovascular and lots of other things. So it's not exclusive to this situation. But the immune system, to put it in scientific terms now, freaks out when it sees LPS. Like, it's like, what the? This is not good. This is not supposed to be here. Like, what is happening? And gets very upset. And that's where inflammation comes from. Estradiol ramps that up. There's actually even some studies that looked at the combo of LPS plus estradiol and what that does to the particularly different parts of the immune system. It's particularly something called macrophages, which are another part of the immune system that seem to be very involved in endometriosis. They're one source I maybe cite in that podcast, maybe or somewhere else, that they characterize endometriosis as a disease of the macrophage.
Yes, it's that one.
This particular part of the immune system is like really freaked out. And arguably that could be happening, that kind of freak out by the immune system in the pelvis could be happening even when there's not lesions, just to cycle back to like, there could be a lot of inflammation even without visible or lesions. So whether it's coming from, as you mentioned, Emmie, like, is it coming up through the uterine microbiome? They don't know for sure, but it's probably one or the other, or possibly both, also translocating from the gut. And if you think about it, the coils of the gut are right there. Like, it's in terms of proximity, like it's literally right there. Like this. So this is leaky gut or intestinal permeability in another sense. Like, it's actually just kind of leaking into the pelvis. And we do know this is like, I don't have the statistics, so I won't try to wrongly quote it, but like a super high number of women with persistent pelvic pain or endometriosis have SIBO, or have irritable bowel syndrome, or potentially small intestinal bacterial overgrowth, which then causes intestinal permeability, which then this is potentially a source of that inflammation. So one, from a functional health, naturopathic health perspective, you really cannot go wrong with addressing SIBO. This would be like a lot of my patients, I would start with that, especially if I know they have gut problems, and SIBO is like, let us start with that. I also use antimicrobial herbal medicines in that setting. So that would be something like berberine, for example, to just let's knock back. So SIBO is in the name, small intestinal bacterial overgrowth. So it's gut bacteria, normal gut bacteria, that have moved up into the small intestine where they're not supposed to be. And that's quite an inflammatory situation. So you might probably have had guesses about SIBO. So you could put that in the show notes, like ways to address that situation and knock back those bacteria in the small intestine. And that can give almost instant relief to pelvic pain to some extent. Yeah. So that's a starting
And
place.
what are some of ones? I know you had a blog post. It's been a while since I looked at it, maybe
Yeah.
at least 2 years. You had
That's
this
fine.
one blog post, I forget what it was called, but it kind of just ran through all the different factors that you kind of take a look at or recommend taking a look at endometriosis patients. I think one of them was nickel, or one of them was
Yeah.
like a histamine diet. Can you kind of run
Yeah.
through what kind of like here's everything you should consider? Or maybe just like top 5 things to look at
Yeah.
with your healing
Yeah.
protocol?
I'm happy. I'll address the nickel thing first and then I'll do a top
Yeah.
5. But yeah, so you can survey your own followers or your own patients, but a lot of women with an endometriosis diagnosis also have nickel sensitivity. You know if you have it because you react to cheap jewelry. You get that. So right.
Get this
That would
ring
be a
rash.
did you get that, Melissa? I'm curious. I'm
Oh,
surveying.
yeah, like,
Yeah.
if
Yeah.
I wore, like, a ring or earring, my skin's green within, like, 6 hours.
Yeah. And like irritated as well. Like that. Yes. Okay. So that's super common. And the way I would see that, I don't see that as therefore nickel is a driving factor. It's more that that's the nickel sensitivity is a symptom of the same freaking out immune system, upset immune system that is involved in the pelvic pain / endometriosis. So yeah, it's a good marker of just how the immune system's reacting. And a lot of that's genetic. So I don't want people, when I say the immune system is upset, I don't want people to think it's because they've done all these wrong things for their immune system. Some people just have a more reactive immune system. A lot of that's going to be genetic there. And it used to be, it's a superpower. Like anything in health has two sides, right? So people who have really strong immune function would have survived the plagues, or there would be reasons. It's just where it's dialed in, kind of where it's calibrated. So if people are feeling bad because they do have quite an inflamed or reactive immune system, it's like, well, that might be why you're here. Your ancestors survived something to pass that on. So, but it does mean we can take that as information that the immune system needs soothing, needs support. So my top 5, and then I'm curious to hear your top 5. I'm sure everybody has a slightly different top. Well, one would be SIBO. I just talked about, like, if there is gut problems, start there, because that, at least in my experience with patients, that is a game changer, and an easy game changer at the beginning to start to feel better. Although there could be a little bit of lag time with pain. I said it can be immediate, but sometimes it can take a cycle or 2. And then going down the list, I guess in terms of the kind of mast cell or immune involvement, I would consider kind of food sensitivities next. So my big one for histamine mast cell reaction is actually dairy, which is interesting because if you were plant-based, you weren't having dairy, or were you when you were?
I was
before
not when
you?
I was
No,
plant-based, no, but I've gone
no.
back and forth between a few years plant-based, a few years back to just normal eating,
Yeah.
so dairy's been in and out, but it's interesting, I was born with a dairy allergy and
Yeah.
kinda of it, but I think that's an indicator too of just histamine issues from a young age, having not allergies, dairy allergies, all this stuff, so it's like I was set up for it at some
I'll
point.
just say that outgrew a dairy allergy. In my clinical experience, I'm curious to hear about you guys from you, but it's often not outgrown. It's often just shifted. The same kind of immune reaction or inflammation that the kid was getting from dairy is now something else. Like is now potentially premenstrual mood or pelvic pain, or it's somewhere else. So as soon as my patients, anytime, as soon as I hear, oh, I had a dairy allergy, but I outgrew it, I'm like, did you though? Or is it playing a role in what's going
Ooh.
on now? So then, and I talk about that in my books. And I guess going down the list, obviously being fully nourished with just everything. The immune system's quite hungry. Like it needs a lot of nutrients. Vitamin A would be a big one for, like, actually, as in real vitamin A, retinol, which is in animal foods, or anyone who's plant-based, that might be a nutrient they want to think about supplementing carefully, because too much vitamin A is not safe during pregnancy, but they can ask their clinician about that. Zinc, selenium, and then that was only number 3, I guess. And then I guess nervous system regulation. So there's lots of people talking about the dysregulation of the nervous system around endometriosis and some of the pain signaling. And once these pain circuits get set up, they can just kind of self-perpetuate, and it's like a little loop, little pain loop. So there's different ways to try to interrupt that. And the autonomic nervous system is very involved in that. So, and then I guess what would you add for number 5, Emmie? I've got some other contenders. So do you have any? thoughts
Oh
that should be on
gosh.
that top
I
five.
mean, did you say sleep? Because
Yeah, well, that would be, yeah. I mean, nervous system
yeah.
regulation is, and also just, I guess, bordering on nervous system of the pelvis is just pelvic floor and the situation of the pelvis. So obviously, pelvic
Mm.
floor spasm does contribute to a lot of pain, and that's going to be true whether or not the lesions are there. So that'd be an example of someone whose their primary pain might be coming from pelvic floor and nervous system, but they also happen to have lesions. So this is where a more holistic approach and troubleshooting some of those things
And
can
that makes me
make
think
a
about
big difference.
trauma, and that's a huge
Yeah,
piece that oftentimes gets overlooked and unaddressed, unfortunately. And that's why there's pelvic floor therapy, and we hear more about
exactly.
that in naturopathic medicine. So that's a big piece.
For sure. And I think that we do, women, in general, or people tend to store trauma in the pelvis. So that, that tracks. Yeah.
Great point. Yeah. What
Yeah.
about patterns on labs, Dr. Bryden? What are you seeing maybe when a woman is struck with endometriosis? Are you seeing maybe any kind of nutrient deficiencies, or I wonder about low omega 3s? What kinds of
Yeah.
things are you seeing tracking on labs?
I just did a whole presentation about this. So that's very good
Oh,
timing because it's
okay,
in
good.
Brisbane. I was at a seminar called, or a convention called Mastering Pathology in Brisbane. That's actually where I got to meet up with Dr. Peta again. But what I tend to do actually with my patients who, if we're suspecting endometriosis or confirmed diagnosis of endometriosis, is look for kind of autoimmune signs on pathology. So I'll screen for celiac serology. So I'll definitely kind of screen for gluten. And I'll be looking for in the family history, if there's any family history of autoimmune disease. I might look for other autoimmune markers like ANA. I will look on also something called thyroid antibodies, which is the anti-TPO or thyroid antibodies is a really common autoimmune marker. And so if everyone listening, autoimmune just means that's when the immune system is attacking um, its own tissue. And I just heard a fantastic quote from this doctor. I forget his first name, Maxwell. He said, when there's intestinal permeability, the gut becomes an auto antibody generator. So basically,
Mm.
the gut becomes the reason that sort of all this autoimmune tendency flares up. And then in terms of other blood markers, another interesting thing with endometriosis is actually it tends to lower androgens. So in that way, it's actually opposite PCOS. There's quite a bit of research around this, actually. Women with endo tend to have lower levels of DHEAS, for example. That's one of the adrenal androgens. So I will sometimes look at that. I'll also look at high prolactin. So prolactin is another female hormone. These are all serum levels. I typically do serum testing. Prolactin is a pituitary hormone it has many jobs in the body, but it can upregulate pain receptors. So, and actually attending to a high prolactin is something we can usually do something about from a natural perspective. So those are some of the tests I talked about in the presentation. What would you add to that, you guys?
I mean, that's a great point as far as looking at other signs of autoimmunity. Even though
Yeah.
we can't say endometriosis is autoimmune, but we're looking at processes, as you have explained so well, that suggest maybe some autoimmune mechanisms here. That makes sense. We think about one autoimmune condition, maybe predisposing to another. And getting a HSCRP, it's so non-specific, but I would be curious to see if someone's showing inflammation in that way also. I'm curious if you see that.
Yeah, I typically don't. I know it's a good point. I typically don't see CRP elevated. I do see ANA elevated, ESR possibly. But to be
Okay,
fair, you can have quite a significant amount of inflammation without any of those things being
sure.
elevated. So, and it's interesting we all, I'm the same. Like, well, we cannot say that it's an autoimmune disease. Like, there's been a lot of angry pushback about that. Especially about
Tiptoeing.
8 or 10 years ago, you were not allowed to say that, which it says something about the rigid thinking around this condition. Actually, which is interesting itself. But I guess big picture, as I say in the podcast that you guys referenced, it's a condition of immune dysfunction for sure.
Mm,
And the thing about autoimmunity, it's quite a broad term already. So I mean, all the different autoimmune conditions have quite different things going on with the immune system anyway. So it's really not a term we have to either really commit to or reject. It's just sort of out there. It's clear in the research there's a super strong correlation between endometriosis and other autoimmune conditions. So what that actually means, you know, it, for every individual is going to vary.
right.
Yeah.
Get comfortable with shades of gray is what I hear.
Yeah, exactly.
And
That's
critically
a great
think
quote.
and
That's a
assess
great quote. Yeah.
research. And yeah,
Yeah.
I hear you.
Yeah, and I've heard some different numbers around just the correlation between being diagnosed with endometriosis and gluten sensitivity and being diagnosed
Yeah.
with celiac. There's a big correlation there. And it's like, well, that's another autoimmune disease. And I've been highly sensitive to gluten since I was like 12. I haven't eaten it in 14 years. And it's now I'm starting to think, I'm like, you know what? I never got tested for celiac. I'm not going to start eating again just to get tested. But I'm like, I wonder if that's something that could be on the table. I'm not sure, but
Do
it's
you
just
have
interesting.
do you have a celiac gene? Do you know, have you been tested for the markers, the
I've not been
HLA?
tested for the gene, but that would be a simple way to rule it out. Just getting tested for the gene to start with to see if that's there.
It would be, I find it helpful for the people like yourself who don't want to eat, as you say, don't want to eat gluten again, to do the serology test. Yeah, my clinical experience is gluten sensitivity is very common in this population of women who have endometriosis slash persistent pelvic pain. I think it's just what I said. It's the type of immune system that you have, which is not, again, not a bad thing. It's just, this is like this a particular sort of immune system where I think that just circle back to estrogen. I think other women, if they don't have that particular type of immune system, or they don't have some of the like intestinal permeability or some of the other things we've been talking about, they can be exposed to huge amounts of estrogen and never develop endometriosis. That's circling back to the cause of, like, the thing you said, estrogen does not cause endometriosis. Lots of women
Yeah.
out there with very high estrogen, and they have other things from it, but they don't develop endometriosis. Yeah.
Yeah. I remember even speaking with a few kind of holistic doctors, integrative doctors, functional medicine doctors, and then being like, oh, well, that probably means you have high estrogen. Let's see what we can do to kind of lower that. And I'm like, actually, my estrogen's it's low. My DHA is
Yeah.
low. All my hormones are low. So
Yeah.
it's not,
Oh,
it's not here, but
do you have
yeah,
low DHEA? Low DHEA?
it's been a couple of years since I tested. I actually
Yeah.
just ordered another urinary hormones test that I'm going to do here in a couple of weeks. But every time I've tested, it has been low. Yeah, but
Yeah,
I've also
that's
put HPA axis dysfunction, the whole 9 yards. I feel like it all kind of like interplays with each other.
well, that low DHEA is pretty consistent. So yeah, that fits the pattern. And again, you don't necessarily have to. Well, in terms of treatment, I'm not sure what that means. I mean, you can sort of do some gentle androgen support. You certainly don't want to be suppressing androgens the way some women need to be. Yeah.
Well, I think it's so
Great.
interesting how you've really been able to like reframe the whole narrative around our overactive immune system and kind of seeing it in a positive light. I like how you
Yeah.
mentioned, hey, your ancestors survived something with this type of
Yeah.
immune system. So I like how you really just reframed that for us today and just talked about even how have you seen some of these superficial endometriosis lesions kind of be eaten up by the immune system and just kind
Yeah.
of like start asking the questions like how can we support the immune system to take care of this by itself so we don't have to go in
Yeah.
and start cutting things and creating scar tissue and getting aggressive in that sense. So
Mhm.
Dr. Briden, you're like one of the greatest voices in this space. I'm so happy that we got to have this conversation today. We'll definitely have to have you back for a part 2 because
Yeah.
we even get to touch on all the other metabolic topics and fertility
Right.
topics. And you've got multiple books out, which we'll link those down below for our listeners. But if anyone tuning in today wants to connect with you, learn more about your work, where can we find you online?
Yeah. Well, I'll just say it's been great talking with you guys. Endo is a very complicated topic, but I think we handled it well, and hopefully we've raised a few points for people to think about. And as part of this, I'll just say again, we're undergoing a pretty big paradigm shift around this condition. It's tough to kind of ride that out in real time, and as new ideas start coming, but hopefully as we go, we'll touch base on this in a couple of years and see where it's all at. But yeah, people can find me. I'm easy to find. So at my blog is larabriden.com. That links to my podcast that you mentioned. All my social media is at Lara Briden.
Amazing. We'll link these down below for you guys. And thank you so much, Dr. Briden, for taking the time today. And for everyone tuning in, until next week, wishing us all vibrant health and wellness.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. Just a reminder, this podcast is for educational and informational purposes and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guest and host are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.